When patients initially present with a diagnosis of metastatic melanoma, I try to group them or categorize them into categories. And I try to put them into a indolent disease, low disease burden, 3 or fewer sites of disease, normal LDH. That's one category, which luckily is perhaps the majority of patients. And then I look to the high LDH, the abnormal LDH, the high tumor burden. We're talking about multiple centimeters worth of linear tumor. Abnormal performance status, symptomatic, which goes with the performance status, say, of 1 or even 2. So in one category is the good actors, and the other category is the bad actors. When you think about a patient who's BRAF mutated, obviously you need to decide are they V600 mutated or not. But of course, when you have a V600 mutated patient, you have to think if you're going to start treatment with BRAF/MEK first, that's generally going to be in the category of patients where you need a quick response. Paradoxically, based on data that we've seen recently published, it's the opposite category that also would be attractive for the use of BRAF/MEK inhibition, and that's the normal LDH, low disease burden, very indolent disease. This particular patient falls into a middle category. Charles is a patient who already has an abnormal performance status of 1. He has symptoms. In fact, he presented with 8 weeks of symptoms. So the disease in Charles' lungs is actually causing issues for him. On the other hand, he does have a normal LDH, and he probably has multiple pulmonary metastases, so he probably has more than 3 sites of disease. So this is someone where you might want to get in a quick hit with BRAF/MEK, and then you might want to consider reverting to the use of immunotherapy. So one creative approach that I take is if someone is in the middle range or has a high disease burden and or is symptomatic, I might give them 4 to 8 weeks of BRAF plus MEK and then do essentially what we would call a forced switch to IPI plus Nivo if I thought they had enough disease burden. And if not, I might go with just a PD-1 drug alone.